Hello guys, Dr. Obin Frimpong here again, and welcome to my YouTube channel, Tutor Med, where everything medicine is simplified. In today's video, we want to discuss an OSCE station. There are two forms of OSCE stations in medical school exam. There is the unmanned OSCE station and the manned OSCE station. For the manned OSCE station, there is an examiner there at the station who would examine you. And for the unmanned OSCE station, there is no examiner there. Usually there is a picture having some clinical condition and then some questions on that paper you would have to answer within a stipulated amount of time. Sometimes there is a clinical entity, maybe say a spinal needle, where questions are asked about the spinal needle and then you need to answer questions on them. Today we want to discuss the unmanned OSCE station, and it will feature a case in internal medicine. And so if you are new here and preparing for any licensure exam, you want to consider subscribing and then hit your notification bell so that you can be updated or notified whenever helpful and simplified videos like today's is posted. Alright friends, without wasting much time, let's begin. And so let's look at our clinical condition. We have been shown this picture, and then there are some questions we need to answer regarding this picture. So the first question says, describe this picture fully. The second question, what is the most likely diagnosis? Then question number 3 says, list 3 other differential diagnoses. Question 4 under this picture, list 6 features of this condition. Question 5, list the investigations that can be done to aid in diagnosis. Question 6, list 4 complications associated with this picture. And then question 7 and the last says, how will you manage this condition? Now it is important for me to emphasize that usually in the OSCE the questions are not as bulky as these. I just made them plentiful like this so we can learn. Usually there are about just 4 or maximum 5 questions under each picture. And so let's take some time to think through the questions and then examine this picture. Then we will discuss these questions in subsequent slides. Have you got your answers down? Okay, let's look at the answers in subsequent slides. Good. And so question 1 said, describe this picture fully. Now when describing pictures in the OSCE, make sure you include all relevant information, even including the presumed sex of the patient. Now, believe me, whether you doubt or not, this patient in the picture is actually a female. And so the answer is, this is a picture of an African woman, not just any woman, an African woman with protruding eyes, which is exophthalmos or proptosis. So aim at describing pictures fully so that you do not get half the marks allocated for that question. And so again, this is a picture of an African woman with protruding eyes. You can end there, but you can continue and put into brackets exophthalmos or proptosis. And so we move to question 2. Question 2 asked, what is the most likely diagnosis? The answer is Gravesdisease. sometimes known as toxic diffuse goiter. So you can simply end at Graves' disease, full stop, and that is the answer. Alright friends, and so before we move to question 3 in this OSCE, let's take some time to look at the overview of Graves' disease. Now, Graves' disease is the most common cause of hyperthyroidism. In fact, according to Davidson's, it is estimated to affect or to be the cause of hyperthyroidism in about 2/3 of patients with hyperthyroidism. It is more common in women than in men. The ratio is 9:1, meaning when you pick 10 patients with Graves' disease, 9 will be women and then only 1 will be a man. It is caused by circulating autoantibodies which have been produced against the TSH receptor on the thyroid gland. So these IgG antibodies have been produced against the TSH receptor, and so this is an autoimmune condition. Now usually autoantibodies are inhibitory, but the Graves' disease autoantibodies are stimulatory, and so they can stimulate the TSH receptors on the thyroid gland, forcing the thyroid gland to produce excess thyroid hormones in an unregulated manner. Remember that the production of hormones is regulated by a feedback mechanism. And so, because this is not regulated by a feedback mechanism, the thyroid hormones are constantly being produced because the autoantibodies are constantly stimulating the TSH receptors on the thyroid gland. Another point I want to make about Graves' disease before we move to the third question in this OSCE is that Graves' disease is characterized by hyperthyroidism and one or more of the following. Either there is a goiter and or there is exophthalmos or protruding eyes, and or there is an infiltrative dermopathy. It means there is a skin involvement in the autoimmune condition, and so it is characterized by hyperthyroidism plus or minus goiter, or the patient might have eye issues or skin issues. Remember that goiter is the enlargement of the thyroid gland. Now let's go to question 3. Question 3 said, list 3 differential diagnoses. And so the possible answers include toxic adenoma of the thyroid gland. Then the second differential we can entertain is a toxic multinodular goiter. And so there are multinodules in the thyroid gland which has enlarged. But remember that in Graves' disease, it is a diffuse enlargement, not a nodular goiter. Then a third differential we can consider is drug-induced hyperthyroidism. And so taking drugs like amiodarone for a very long time may also cause hyperthyroidism. Then we've been asked for 3, and so we stick to 3. Please do not give more answers than has been asked of you. But other differentials we can consider is plumar disease. So plumar disease is also a pathology with the TSH receptor, but this time, unlike Graves' disease, it is not being stimulated by an antibody. There is a gene mutation of the TSH receptor itself, which is giving a toxic adenoma or multinodular goiter. So that is plumar disease. Then sometimes inflammatory thyroid disease may cause hyperthyroidism. Now, if we get out of the thyroid world, sometimes if the patient has an intracranial tumor occupying the frontal or anterior cranial fossa, it may cause the eyes to protrude even without a thyroid problem, and so intracranial tumors may also do that. There are several other causes of hyperthyroidism, even including molar pregnancy. Sometimes molar pregnancy or gestational trophoblast disease may be associated with hyperthyroidism. Question 4 was asking us to give 6 features of this condition. Now, for this question, I like to look at the clinical features of Graves in 4 ramifications. 1, a patient with Graves would have features of hyperthyroidism, and so we will look at those features. Then remember, it may be associated with a thyroid gland enlargement, that is goiter. It may be associated with eye changes, that is Gravesdisease, also known as infiltrative ophthalmopathy. Remember, ophthalmopathy simply means eye disease. Then it may be associated with Graves' dermopathy, that is infiltrative dermopathy. And so these are the clinical features of Graves. Features of hyperthyroidism: there may be a goiter, there may be eye involvement, and then there may be skin involvement. And so we are going to look at these features in subsequent slides briefly. Then we'll select 6 answers out of them and put them as our answer. And so let's begin with features of hyperthyroidism. And so there will be features like heat intolerance, weight loss despite increased appetite for food. There might be palpitations, diarrhea, excessive sweating or diaphoresis. There might be hyperactivity, tremors. And so these are a few features of the hyperthyroidism, and this is linked to increased adrenergic stimulation. This list is not exhaustive, but these are a few symptoms. There may be nervousness as well. Yes, and the other features include a diffuse goiter. It is very important for you to put the word diffuse there, because goiter can be nodular or diffuse. And then the goiter of Graves' disease is a diffuse one. It is not multinodular or nodular. Then another feature is Graves' ophthalmopathy. And like we established in the 2 previous slides, it is known as infiltrative ophthalmopathy. So the pathogenesis is not clearly understood, but it is believed that the autoantibodies also bind to some receptors in the orbit, including the fat in the orbit, and so that induces an inflammatory response, and then the edema in the orbit kinds of pushes the eye out, and that is responsible for the eye signs. And so you may see a stare. The patient looks at you, although it's not staring at you, but there is a stare. That is how the eyes would look like. Then there is something we call eyelid lag or simply lid lag. There is eyelid retraction, and then there might be mild conjunctival injection. This has also been linked by increased adrenergic stimulation. So like I said, the pathogenesis is not really understood according to the literature I used, Merck's manual. Then we have Graves' dermopathy. Again, it is also called infiltrative dermopathy, sometimes known as pretibial myxedema, which is really confusing because when we talk of myxedema, we mean hypothyroidism. But this condition is also called pretibial myxedema. And so there is a non-pitting. It means when you press the pretibial side, the edema there is not pitting. So it's a non-pitting infiltration of some proteinaceous ground substance, particularly in the pretibial aspect of the leg. And sometimes this is pruritic, sometimes it's very itchy. Yes, and apart from the skin changes, some other things can occur in the integumentary system. So when you pick the fingers, the patient may have a clapped finger, a condition called thyroid acropathy. And so our answers, we want to pick them. For the 6 features, we would pick a diffuse goiter, then we'll mention diaphoresis, would mention increased weight loss despite increased appetite, would want to mention tremors, would want to mention heat intolerance, we would want to mention palpitations. We would not add any feature of Graves' ophthalmopathy because that is what we see in the picture. To avoid being marked that we've repeated an answer, we would want to avoid that part and then list other things we didn't see in the picture. And so question 5 was asking us to list the investigations that can be done to aid in diagnosis. Kindly note that investigations that can be done to aid in management, the answer to that question is different from investigations that can be done to aid in diagnosis. And so here we want to mention some diagnostic investigations, including, so for an answer, the first thing we want to know is whether the patient is hyperthyroid, and so we want to do a thyroid function test. Remember, TutorMed has treated thyroid function test, a very comprehensive lecture, and so if you are not familiar with the interpretation of the thyroid function test, please have a look at that lecture. I will post the link below. Have a look at it and then get yourself acquainted with the interpretation of thyroid function test. Then we also want to do the TSH receptor autoantibodies. They are very good for screening for Graves' disease. So the thyroid function test will tell us that there is hyperthyroidism. Then we can go on to do the TSH receptor antibodies. Sometimes you can add other thyroid autoantibodies like the antithyroid peroxidase and then the antithyroglobulin antibodies. If you've watched a video on thyroid function tests, you would have come across these enzymes. So the peroxidase helps in taking the iodine into the thyroid gland or the thyroid follicle, and also helps in organification. And then antithyroglobulin or thyroglobulin, that molecule is actually the organic molecule from where thyroid hormones are synthesized. When you couple the oxidized iodine to the thyroglobulin, that's why you say that you've organified the iodine. And so please take note of that. Antibodies against the peroxidase enzyme and then the thyroglobulin molecule can also be screened for, but they are not specific for Graves' disease like the TSH receptor autoantibodies. And then if there is an anterior neck swelling or a goiter, you may want to do a thyroid ultrasound scan. And so investigations like ECG, investigations like echo, no, they are just there to help you see if there are any complications like atrial fibrillation or thyrotoxic cardiomyopathy, but they don't help in diagnosis. And so note that the question was asking for investigations which can be done to aid in diagnosis. All right, and so question 6 was asking, list 4 complications of this condition. And so the suggested answers, we have thyrotoxic cardiomyopathy. This is heart failure from hyperthyroidism. So it's a high output heart failure, it also causes dilated cardiomyopathy. And so thyrotoxic cardiomyopathy is simply heart failure from hyperthyroidism. Then hyperthyroidism can also cause atrial fibrillation, so we take note of that. Then there is a complication called thyroid storm. Thyroid storm is the acute form of hyperthyroidism. It usually manifests because someone has hyperthyroidism and then we didn't treat it, or we treated it but it is poorly treated. So if that happens, we can have an acute form of hyperthyroidism, that is thyroid storm, which can be potentially fatal. Sometimes it can be precipitated by infections, can be precipitated by trauma, surgery. Sometimes someone with pulmonary embolism can, if he has an underlying Gravesdisease, can have thyroid storm. Sometimes thyroid storm can be precipitated by DKA. Then another complication is osteoporosis. So 4 answers, we are okay. But it can cause menstrual irregularities, sometimes can cause gynecomastia, etc. Alright friends, the last question said, how will you manage the condition? So the condition we've been shown. So we know that the patient has Graves' disease with eye signs, because obviously the picture is telling us that there is Graves ophthalmopathy. And so for the answer, we want to manage the hyperthyroidism. Okay, and so we can give anti-thyroid drugs. The drug that we use here commonly is carbimazole. So we can start with an appropriate dose. I think in the US, instead of carbimazole, they use methimazole. Other options include propyl thiouracil. Then how do we administer these anti-thyroid drugs? We have two methods or 2 regimens, as it were. So we have the titration regimen and then the block and replace regimen. So for the titration regimen, you start with an appropriate dose of the anti-thyroid drugs, paying attention to the thyroid function test. Then you treat the patient for about a month or so and repeat the thyroid function test. And if it has gone, if it is now better, you can reduce the dose of anti-thyroid drugs you are given. So essentially, you are titrating the dose of the anti-thyroid drugs against the report, so that if you repeated it and then the hyperthyroidism seems worsening, then you have to upgrade your dose. So you are titrating. That's called titration regimen. Then there is a block and replace. So that one, you give the anti-thyroid drug, but you replace the anti-thyroid drug again with levothyroxine. The problem with the titration regimen is that sometimes when you are giving the anti-thyroid drug, you might cause iatrogenic hypothyroidism, because you are not repeating the thyroid function every day. You are doing it monthly. So there may come a time that your anti-thyroid drugs might dip the patient to hypothyroidism without you knowing. But the block and replace regimen reduces the chances of iatrogenic hypothyroidism. The superior under whom I train has been using the titration regimen, and so I am tempted to say that is the most commonly practiced regimen used when you are managing a patient with hyperthyroidism from Graves' disease. But it is important for you to know that we have 2 regimens, the titration regimen and then the block and replace regimen. And the fact that the block and replace regimen decreases the chances of iatrogenic hypothyroidism. Then you don't only give the anti-thyroid medications, you may have to manage the symptoms with a beta blocker. So a beta blocker like oral propranolol can reduce symptoms like tremors, the diarrhea, the palpitations, and even the eye signs. Propranolol is the most preferred, but if you don't have propranolol, literature says you can use atenolol or metoprolol. Then for the eye signs, you might need to refer the patient or consult an ophthalmologist. And so for the infiltrative ophthalmopathy, it has to be co-managed by the ophthalmologist and then the endocrinologist or the physician. It is important to note that we need to refer the patient for ophthalmology referral, because the ophthalmologist might help prevent complications like keratitis because the patient's eyes are constantly exposed, and so the ophthalmologist might request some eye drops like methyl cellulose eye drops, maybe taping the eyelid so that we don't expose the cornea too much to prevent corneal abrasion. And sometimes they may use steroids for the protruded eyes. Then another option, or a last option, is surgery. So you can do thyroidectomy, usually a total thyroidectomy, and then replace the thyroid hormones by giving levothyroxine. However, the surgery is indicated in patients who for some reason are not tolerating the anti-thyroid medications, or who have had several courses of the anti-thyroid medications but they are still not getting better, or patients who have a large goiter which is causing obstructive symptoms and so might require surgical intervention, whilst bearing in mind that the parathyroid glands are also within the thyroid, and so when we are doing a total thyroidectomy, we might have to also be thinking of hypocalcemia as a complication and then manage it accordingly. And so this is the end of today's discussion. Thank you for watching, and see you in our next video. Until then, bye.